I will talking about a little bit about the adult stem cell aging and the skeletal regenerative medicine. So as we know, we have many types of stem cells, very hot in these days. The people research the embryo stem cell, also the IP cells. What I'm talking today is the adult stem cell, which in many tissues, especially in the bone marrow, that's studied. Today we're talking a lot about the mesenchymal stem cell, also in the fan tissue. Also I have MSCs. Another very hot adult stem cell is blood stem cells. As we know, when the tissue damaged, the first line of the repair is the local stem cells. For example, in the liver, in the skin, just talking, the last speaker talking about in the instance. When the tissue damaged, they have inflammation factor which give the signal to the stem cell. The stem cell become active and then repair the tissue. When the local stem cell cannot do the job, they will become blood stem cell in the circle, come to the injured area to repair it. When we're young, the most case, the local stem cell or the circle stem cell can repair most of the damage. When we become aged, the adult stem cell regenerative capability become decreased, either because we have less stem cell number in the tissue, or the adult stem cell lost repair function. So when we age, or in some cases disease, when the local stem cell cannot repair, either we can use some drug which can activate the stem cell, or we use stem cell transplantation to help the local stem cell to repair the injured tissues. Another line of use adult stem cell to do the regenerative medicine is to use stem cell and the tissue engineer, and a lot of speakers talking about that in this morning. So that involved the patient own stem cell and cut them in vitro and put in type cut scaffold, which plus growth factor and other factors, and either you go to the patient or you cut them in vitro. In vitro can produce some type tissue and then transplant back to the patient. So today I'm talking about the mesenchymal stem cell as an example to tell a little bit about adult stem cell aging and regenerative medicine. So as we know, the mesenchymal stem cell, and I just take one example in the bone marrow mesenchymal stem cell, which can differentiation to all the mesenchymal tissues like the cartilage and the bone. Also can trans-differentiation to other type tissue like neuron and the lung. Because the bone marrow stem cells are very easy to culture, to isolate, and culture in vitro. That's why we use a lot in the regenerative medicine. So that's how they look like. Also, they like fibroblasts. They have some mark. So it's a marker pattern. Not today is no space marker for them cells. Also, if you cut them in the low density, they can form a cloning. They call it a cloning forming unit fibroblast. And by counting this cloning, you can know the stem cell number in vivo. For example, in the newborn, you have about 10, so that bone marrow cell, you have one mesenchymal stem cell. When we growing, the stem cell number is a significant decrease. For example, in the 18th, you have 2 million bone marrow cell, you have 1 cell. You can imagine when the tissue needs this type of cell to repair, for example, bone, in the newborn baby or the teenager, because you have enough stem cell, it's easy to repair it. If we aged, because the cell number is not didn't have enough cell to do the job. So that's how it looks like when we cut them in vitro. You take one MCs from a young patient, they look like really fibroblasts in the very thin shape. When we take the same cell, cut them in same percentage from the old patient, they look like that. They are very large and senescence. So when we quantitative the senescence cell in this type of culture, we can stain them by a very old senescence marker, the senescence-associated beta-GAR. So that blue cell is the senescence cell, and then we counted them correlation with the patient age. We find it's increase with age, especially in the middle age. In the between 50 and 60, you have significant increase. That's why we define the young patient as less than 50, and the old patient is more than 55, basically this data. So with age, not only you have more senescent cell, also the cell proliferation is slower. For example, in the cell doubling time is significantly correlation with the patient age. Also, the cell have less differentiation capability. For example, in the differentiation to osteoblasts, and as you saw, marker alkaline phosphatase is a negative correlation with patient age. Then they have less gene expression or the osteoblast mark. That's another method to measure the osteoblast differentiation capability, also decrease with age. To summary our data is with age can inhibit the cell self-renewal or proliferation, also can decrease the differentiation capability. That's why you have less, with age they have less stem cell, the stem cell have less differentiation capability, than why you have less osteoblast. Then the bone formation capability is decreased. That's one of the reasons why we have this type osteoporosis shape, like this 3 Korean women. You have the middle age, because the spine is like that, and then you can, because the spine is shrink, so that's why I have this type old lady shape. So as we talking before, we can use some drug or compounds which can stimulate the adult stem cell. Here is MC's proliferation or different capability. In recent years, we published a lot of paper. We find the PTH, vitamin D. For example, PTH can stimulate the cell proliferation and can stimulate osteoblast differentiation. When we aged, the cell from the old patient have less PTH receptor, and then they are less responsive to PTH. That's why PTH can not stimulate the osteoblast differentiation capability is decreased. When we use something to increase the PTH receptor in the cell, the old cell can respond to PTH treatment. Also, the same story, vitamin D. When we age, the mesenchymal stem cell have less, the VDR level is decreased. So now I'm talking a little about the human skeleton. We know we have mainly is bone cartilage. And because they are structure different, the bone have a very high capability to repair itself. For example, bone fracture, because you have blood vessel come in, the blood vessel can bring growth factor. Also, most importantly, the blood vessel can bring the stem cell come to the fracture side, can do the fraction. In the cartilage, because you have no blood vessel in cartilage, when cartilage damage is very hard to heal by itself. So that's the OE drawing, and your different level of the damage by the OA grade, like grade 0 is normal, grade 1 a little bit damage the cartilage, and then increase the grade until totally the cartilage lost. It then show the subchondral bone. So one of the technology to repair the damage of the cartilage, they call it a microfraction, which is draw a hole to the cartilage and release the bone marrow from the subchondral bone. The bone marrow and the blood come here to burn the stem cell, mainly it's a mesenchymal stem cell, come to the damage the cartilage, which can differentiation to chondrocyte, can repair the damage the cartilage. When that's a minor injury can repair like that. When you have a major, most cartilage was damaged, you have to do the total hip replacement. So another way to repair the cartilage can use a tissue engineer, which can take the stem cell, mesenchymal stem cell, but the bone marrow you put to a 3D culture. Either you can differentiation to chondrocyte in vitro, or you transplant back to the damaged cartilage, can repair it. So in several years ago, we published a paper to show differentiation the mesenchymal stem cell to chondrocytes can stimulate by TGF-beta and Wnt. When TGF-beta Wnt can cooperate to stimulate the MCs to chondrocytes. Also, we use some scaffold, the collagen scaffold, and plus dimorelobone, which can induce mesenchymal stem cell to chondrocytes. And the cartilage scaffold itself is no induced factor, which cannot differentiate. So far, we have a lot of, in the world, around the world, they have a lot of clinical trial to test the mesenchymal stem cell to repair the articular cartilage defect. And one example here is the Japanese study, which a case-report study to show the damaged cartilage. You put a scaffold and MSCs, put in the damaged area in several months. They show repair the cartilage, but you see the detailed structure is not articular cartilage. It's like a fiber cartilage. So we have different type of cartilage. The most difficult to repair is the weight bear area, like the joint cartilage. Other type of cartilage, like the airway tube, which can very easily to tissue near produce can useless. For example, just in this type of scaffold, you put the MCs, put the pseudomice, you can produce real airway tube. That's the example in the Borden Children's Hospital. One doctor take the MCs from the amniotic and put it to a scaffold, because this have develop disease in the airway, this baby. They just produce this type of airway tube in the lab. When the baby born, it's transplanted back to the baby. That's the example of the European study to show use a decellular torture airway tube. You put the autologous MCs plus growth factor can produce this type of tube cartilage transplant to the patient successfully. Another area, the MCs in the tissue engineer, that's also a European study to show to human face, rebuild the human face. They use this type of scaffold to put the bone marrow and BMP7, and put back to the human, put it into the muscle. That they call it a human incubator. And several weeks, they transfer back to the human face. They show they can replace the defect of the bone. That's some. You can think about in the future in the osteopathic clinic. We really need the translational research with the bench and the band-side interaction. For example, when the clinician find OA hip, we can use a computer to measure the hip, can design, according to the size of the hip, design this type of scaffolds. And then use the 3D bioprinting and the scaffold material with the MCs, and to use a tissue linear device. Either you incubate this stem cell plus scaffold in the lab, in the bioreactor, or put it to a human incubator, and to make real MCs, the hips transplant to the patient. That needs more research on this area. That's thanks my lab member and the collaboration from our medical school, Harvard University, and Pittsburgh. Thank you. Yeah, that's use the PTH, treat the cell, can upregulate the VDR.
Upgrade the number of VDR?
Yeah, we did the gene expression at protein level.
How about vitamin K2? Do you use that
No.
to do anything?
We never try that, yeah.
Sorry about the misquoted.
Okay, thank you.
That's a question?
Yeah.
Okay, very nice work, thank you. Do you list a couple of health hormones to induce the some bone recovery or the healing process? Do you have any developing data to show you any single hormones will change any stem cells or cartilage damage in the process for?
We never try that. We tried the TGA beta, also some growth factor. We never tried the hormones. The hormone is mainly is in the osteoblast diffuse this direction.
Any other? No other questions?